Anthony DeMaria returns, this time with Dr. Francesco Mattace-Raso, Assistant Professor of Medicine at the Erasmus Medical Center in Rotterdam, Netherlands. They cover intrinsic changes in the cardiovascular system. What is normal aging and what is disease?
I have wondered about that for these many years, Francisco. What is normal aging?
There are some processes which are associated with aging. I mean, we are born as humans and we are programmed to live several years. So some structures will change and these changes will have an influence on our function. But this aging process has relevant interactions with environmental factors and events which will find place in our life. So it's difficult to explain what can be normal aging and what can be pathological, let's say, aging.
Yeah, that's really the question, because we know there are certain identifiable changes that occur in the cardiovascular system with age,
yes,
at least statistically speaking, in terms of left ventricular wall thickness, left atrial size, and
yes,
whatnot. And so then when is that a normal aging process, anticipated aging process? When is it pathological, or is aging itself pathological?
Maybe if you should speak to gerontologists, will tell you that aging itself is pathological. But I don't know whether this is the truth. But in medicine, we use lots of, let's say, arbitrary measures, like saying that blood pressure levels of under 42/80 would be hypertension when compared to levels of 138/80. So it's quite arbitrary. But you must have some boxes, you must have some cutoffs in order to make decisions and to predict risk and or decide to treat patients. We have been discussing about that some minutes ago. I think it is very interesting to look, for example, at the structure of the vessel walls. And one of the most important components of the vessel wall is elastin, a protein which confers the sensibility to the vessel walls. And we know, for example, that the half-life time of elastin is 50 years. So maybe you might assume that after the age of 80, the important degeneration progress will start, and at least if we talk about the cardiovascular system, and give more space to atherosclerosis, arteriosclerosis, and the consequences of that on blood pressure levels and cardiac function.
So just to make sure I understand you, the lifespan of elastin is approximately 50 years. And I take it you're timing this from birth or from full maturation?
From birth,
so
yeah.
That 50 years of age may be a kind of a marker of a change in aging where some more abnormalities of vascular
could be present. Maybe you can talk about accelerated aging of the cardiovascular system when some conditions are present, for example, hypertension or diabetes mellitus. We know, for example, that in terms of cardiovascular systems, persons with diabetes mellitus are biologically 10 years older than subjects without diabetes mellitus in terms of cardiac function, in terms of cardiovascular risk. So I think this is an interaction between what we are programmed for and environmental factors.
So one of the questions that intrigued me when I was editor of JACC was that I would see manuscripts come in and they describe heart disease in the elderly or heart failure in the elderly or arrhythmias in the elderly, whatever. And sometimes the elderly was over age 60, sometimes over 65, sometimes over 75. So what is the definition of old age or elderly, and how do we identify that?
This is a very good point, and actually I have no correct answer for this. In my personal idea of being old is when you quit with activities you have been doing as young adults. And maybe it's due to disease, it's due to disability, or just because you don't want to do it anymore. When I was a medical student, which was in the previous millennium, the definition of elderly was 65. I think that if you call elderly, old men, someone who's 65 now, will be upset about that. Thereafter, when I was a resident, there was another limit or another cutoff of 70. And now, indeed, the challenge is what about the very elderly? So when you're 80 plus. Why? Because we are aging, there are still more elderly, but more important, there are still more active elderly. So what are we going to do with these persons when they have hypertension? Why should we keep on treating diabetes mellitus and not to treat hypertension, for example, in 80 plus? And then the second step is where the treatment of risk factors has still an effect on, in this case, cardiovascular risk reduction.
But didn't the HIVET study show that treating octogenarians with hypertension yielded benefits?
Yeah, you're absolutely right. Yeah, the HIVET study showed this, and I know that many colleagues do not agree with this, and they suggest that the population was too healthy. And maybe this is true, but I think this should be the target of medical doctors, to identify subjects at risk and to decide which subjects have to be treated.
You probably know in many countries in this world there's a mandatory retirement age from medical practice, at least in the structured setting, of 65 years. Yeah. Does that make any sense?
Well, I think that if you look at the large numbers, then you would say, no, it does not make any sense. But then you always have to look at the individual. Maybe you could also think other functions for medical professionals. I think, for example, of the professors who have to retire because they are 65, and although they could be great teachers for young students and share their experience.
Yeah, but the point is, for instance, for surgery, that's the easiest one to consider. Is there any reason to believe that at some age, the majority even of surgeons lose their ability to make cuts and tie knots?
I do not think so. And you also see this in this society because you see more and more 70-plussers, for example, on a tennis court playing tennis, but maybe just like in case of driving license, maybe a sort of re-exam of your skills might be indicated.
I mean, this has been an interesting conversation and an important one, but this is almost like the chicken and the egg question. What came first? Is the process of aging pathological in and of itself, and are there some changes that are appropriate for age that we should just accept and not consider pathological? And I don't know how we're ever going to answer that question.
Maybe not, but I think we are now confronted with a new category of patients. 30 years ago, patients who had MI could die of that. Now these patients, they get an angioplasty and they can live longer, which will expose these persons to a higher risk, for example, of a stroke and thereafter of a dementia. In other words, what we have seen in the last maybe 20, 30 years is the upcoming of a new category of patients, which are the chronic patients. Not only cardiovascular, think of the Parkinson's disease, for example. These persons live longer. So we have a new category of patients, and for these patients we still don't have exact guidelines. So that's why trials and other studies, such as the HIVET study, will be performed in order to assess the value of treatment in this, let's say, new category of patients.
Well, thanks very much for sharing your thoughts. This is a provocative topic that will remain so. Thanks for being with us.
It was my pleasure. Thank you very much.
Our final subject for this edition of ACCEL features the discussion Victor Ferrari had with Dr. Ronald Whittles, Assistant Professor of Medicine and Co-Director of the Stanford Amyloid Center at Stanford University in Palo Alto, California. They cover cardiac amyloidosis.
Tell us, what is amyloidosis and how have things evolved over the years to identify some of the subtypes in terms of genetics